Welcome to the video lecture on bloodstream infections. In today's class, we're going to learn the definition, various terminologies related to bloodstream infections, types, risk factors, causative agents, pathogenesis, and laboratory diagnosis of bloodstream infections. What are bloodstream infections? In simple terms, it is microbial invasion of the blood. But the appropriate definition is bloodstream infections are defined as one or more positive blood cultures associated with systemic signs of infection such as fever, chills, hypotension, etc. What do you mean by one or more positive blood cultures? If in the first blood culture the pathogen is isolated, that's sufficient. But if a commensal organism is isolated, you need to repeat the blood culture, and if the same commensal is isolated in the second blood culture, then it is considered as a pathogen. Types of bloodstream infection. Based on the site of origin, there are primary and secondary bloodstream infections. Primary bloodstream infections, the microbes directly invade the bloodstream without any other site of infection in the body. Examples are endovascular infections. In secondary bloodstream infection, there is a secondary focus of infection like urinary tract infection or respiratory tract infection from where the microbes enter the bloodstream. Based on the place of acquisition, they are nosocomial or healthcare associated bloodstream infections, community acquired bloodstream infections, and maternally acquired bloodstream infections, that is transplacentally transmitted from mother to fetus, like TORCH group of organisms. Looking into the key issues, bloodstream infections often are iatrogenic owing to invasive procedures or placement of devices like catheters. And in this context, catheter-related bloodstream infections are the most common cause of healthcare-associated bloodstream infections. Sepsis is the most common cause of death in intensive care units, and estimated mortality rate due to bloodstream infections is around 12 to 25%. Let us look into various terminologies. The definition of bacteremia. The microbiological definition is the presence of viable bacteria in blood without any multiplication. Because they're not multiplying, usually they do not cause infection. Septicemia. The microbiological definition of septicemia is presence of and multiplication of bacteria in blood, and also presence of bacterial products in the blood. What happens clinically? This results in severe inflammatory reaction in the body, manifesting as fever, chills, hypotension, etc. Similarly, there are terms like fungemia, presence of fungi in the blood, viremia, presence of virus in the blood, and parasitemia, which is presence of parasite in the blood, parasites in the blood. Let us look into types of bacteremia. They are transient, intermittent, and continuous bacteremia. Transient bacteremia occurs spontaneously or with minor events following any chewing of food, brushing of teeth, or following any dental procedures, endoscopy, or surgeries involving non-sterile sites like vaginal hysterectomy, transurethral resection of prostate. All these lead to transient bacteremia because the bacteria which enter are small in number, so they immediately eliminated by the reticuloendothelial system, and usually they do not cause septicemia or infection. Intermittent bacteremia is seen in undrained abscess and in early course of meningitis, pneumonia, and pyogenic arthritis and osteomyelitis, wherein the bacteria enter the blood intermittently. Like in undrained abscess, the bacteria enter the bloodstream 45 minutes before the febrile episode. Continuous bacteremia is seen in endovascular infections like infective endocarditis, for example, and also during first few weeks of typhoid fever and brucellosis, where bacteria enter the bloodstream at a constant rate. Let us look into the progression of bloodstream infection. The bloodstream infections start off as SIRS, which is systemic inflammatory response syndrome, and proceed as sepsis, severe sepsis, septic shock, finally resulting in multi-organ dysfunction syndrome or MODS and death. Let us look into each of these terms. Systemic inflammatory response syndrome is a non-specific inflammatory response of a body to an insult, which can be an infection or other causes like burns, trauma, surgery, etc., and it is characterized by fever or hypothermia along with one or more of the following. It can be either tachycardia, tachypnea, leukocytosis, or leukopenia. Then what is sepsis? Sepsis is systemic inflammatory response syndrome due to documented infection. It's due to infection, not due to any other cause. So here you can see that the circle towards the right, which is systemic inflammatory response syndrome, can result either due to infection by bacteria, fungi, viruses, parasites, and due to other causes like trauma, burns, surgery, pancreatitis, acute mesenteric ischemia, etc. But the systemic inflammatory response due to infection is called as sepsis. What is severe sepsis? It is sepsis along with acute organ dysfunction, that is new onset organ dysfunction, not the chronic one. It can involve cardiovascular system, central nervous system, respiratory system, etc. What is septic shock? It is severe sepsis along with refractory hypotension, the hypotension which is not responding to fluid resuscitation. So we need to give vasopressors or steroids. Septic shock can finally lead, if untreated, if unmanageable, leads to multi-organ dysfunction syndrome and even death. What are the risk factors of bloodstream infection? Extremes of age. Too young, the immune system is immature. Too old, the immune system is weak. Any underlying diseases like diabetes, malignancy, or the person is receiving any immunosuppressive agent. Presence of any septic focus like urinary tract infection. From the pathogen causing the urinary tract infection can enter the blood causing urosepsis. Surgical procedures and invasive procedures, especially the catheter associated bloodstream infection, and antibiotic resistance. What are the sources of infection? They can be intravascular or extravascular. In intravascular, the microbe is directly entering into the bloodstream. It occurs with endovascular infections like infective endocarditis, and it's associated with colonization of intravascular devices like catheters, subcutaneous ports, or even vascular grafts can be colonized to cause a bloodstream infection. Extravascular sources are genitourinary tract. We discussed about the urosepsis, respiratory tract, intra-abdominal infections, which reach the bloodstream via the lymphatics. What are the causative agents? They are bacteria, the most common cause, which include gram-negative bacteria, gram-positive bacteria, and anaerobic bacteria. Fungi are the less common cause of sepsis, and among the fungi, Candida is the most common cause. Viruses and the parasites are the rare cause of sepsis. Let us list the bacterial agents which cause bloodstream infections. Gram-positive agents are Staphylococcus aureus, Staphylococcus epidermidis, Pneumococci, Streptococcus pyogenes. Group B Streptococci or Streptococcus agalactiae, Viridan Streptococci, Enterococcus, Listeria monocytogenes, Mycobacterium species. It could be Mycobacterium tuberculosis or atypical mycobacteria. Gram-negative bacteria include E. coli, Klebsiella, Enterobacter, Pseudomonas, Salmonella, Neisseria meningitidis, and Haemophilus influenza. Other agents include HASSEC group. HASSEC group includes Haemophilus species, Aggregatibacterium, Cardiobacterium, Echinella, and Kingella. Other bacteria are Bartonella, Coxiella, and anaerobes like bacteroids, Fusobacterium, Clostridium, etc. The list of fungi include Candida, the most common cause. Others are Aspergillus, Mucor, Rhizopus, Cryptococcus, Fusarium, Pneumocystis, etc. The list of viruses include herpes simplex virus, dengue, influenza virus, enteroviruses like Coxsackie and Echo, etc. Parasites include Leishmania, Trypanosoma, Babesia, malarial parasite, Filaria, and Schistosoma. Let us look into the infective endocarditis causative agents. The native valve endocarditis is most commonly caused by Staphylococcus aureus, and prosthetic valve endocarditis. Before 12 months of replacement, the most common agent is Staphylococcus epidermidis, and after 12 months of replacement or placement of prosthetic valve, the most common agent is Viridan streptococci. Among IV drug abuse individuals, the most common agents are Staphylococcus aureus and Enterococcus, and other agents include Hasek group, Pneumococci, Bartonella, and Coxiella. Looking into catheter-related bloodstream infection, the diagnostic criteria of catheter-related bloodstream infection, the catheter criteria is presence of central line for more than 48 hours. Clinical criteria includes presence of clinical signs and symptoms like fever, hypotension, tachypnea, etc. And culture criteria includes differential time to positivity. That is when you have to draw the blood from the central line and the peripheral line, and the central line culture should come at least 2 hours, should come positive at least 2 hours earlier than the blood collected from the peripheral line. Looking into the pathophysiology of bloodstream infections. Following the infection, the host mounts an pro-inflammatory reaction against the pathogen. That is, it releases cytokines like tumor necrosis factor and interleukins, which causes endothelial dysfunction. This results in dysregulation of coagulation and fibrinolysis, leading to tissue injury. Simultaneously, the host is also mounting an anti-inflammatory reaction, which is resulting in mitochondrial dysfunction. So this impaired cellular oxygen extraction resulting in organ dysfunction and death. Now let us look into the laboratory diagnosis. It includes microscopy, culture, especially the important gold standard is the culture. We have to perform blood culture, and if in extravascular, when the source is extravascular, we can collect other samples like sputum if it's respiratory tract, urine if it's urinary tract, and so on. Other method is toxin detection, serology, molecular methods, and other lab tests include detection of biomarkers like procalcitonin is an important marker indicating bacterial infection. C-reactive protein is a non-specific marker of infection, and other lab tests include renal function tests, liver function tests, and coagulation profile, etc. Looking into microscopy, the Buffy coat smear of EDTA blood is stained with Giemsa or Leishman stain to detect parasites like trypanosomes, amastigote forms of Leishmania, malarial parasites, and microfilaria. Under culture, let us know about blood culture. In blood culture, the specimen is collected, the blood is collected from is peripheral venous blood. But if it's catheter-related bloodstream infection, you have to collect the blood from the peripheral line as well as central line to check for differential time to positivity. Now let us look into how this venous blood sample is collected. First, the healthcare worker should wash his hand, check for the site, check for the suitable vein, palpate it, then wear the glove, decontaminate or disinfect the area with an alcohol swab, draw the blood and inoculate into 2 bottles. Usually one is aerobic blood culture bottle and another is anaerobic blood culture bottle. So 2 bottles is 1 blood culture set, followed by labeling, writing the patient's name and the details, and sending it or transporting it immediately to lab. So here we have to remember from one site we are collecting 1 blood culture set, which includes 2 bottles. Usually it is 1 aerobic blood culture bottle and other is anaerobic blood culture bottle. Further looking into specimen collection, what is the timing, what is the best time? The sample should be collected as early as possible and before starting the antimicrobial therapy. And what is the volume of blood collected? In adults, the minimum volume required is 10 ml per bottle. So totally you have to collect 20 ml blood to inoculate into 2 bottles. And in pediatric patients, depending on age, it ranges from 1 to 5 ml. In neonates, it's just 1 ml. As the age increases, you can increase the amount of volume of blood. Looking into number of blood cultures you have to perform, the standard is at least collect 2 blood culture sets from 2 different sites. And in case of endocarditis, you have to collect 3 sets from 3 different sites within 1 to 2 hours. And in case of fever of unknown origin, initially 2 blood culture sets are collected, and if it's positive, it's okay. If it's negative, Within 24 to 36 hours, you have to collect 2 more sets. What is the culture media used? Usually we have seen that for other culture, we are inoculating the sample onto solid media. But for blood culture, the blood is collected from the patient and on the bedside, it is inoculated into the broth media. The culture media include are trypticase soy broth or brain heart infusion broth or Columbia based broth, etc. And the various nutrients present in this broth. And one of the ingredient present is sodium polyanethol sulfonate, which is an anticoagulant, because once we add the blood, it should not clot. Another action of SPS is it is also counteracting the bactericidal action of blood. Blood is having WBC and complements which might kill the bacteria present in the blood even before we culture. So SPS is helping acting as an anticoagulant. Also, it's counteracting the bactericidal action of the blood. And what is the volume of media in each blood culture bottle? In a pediatric bottle, the volume of the broth is 20 ml, and in adult bottle, it can range somewhere around 40 to 60 ml. So as soon as you collect the blood, you at the bedside itself, you are injecting the blood into the bottle without removing the cap. You are injecting to the rubber cap, and say if it's adult, you collect 20 ml, and in one bottle you are injecting 10 ml. So it's 10 ml blood into somewhere around 50 ml broth. So we are doing 1 in 5 dilution. Why are we doing this dilution of broth? To counteract the bactericidal action of WBCs and complement present in the blood. And so ideal blood to broth ratio is 1:5 to 1:10. The next, you have to incubate this blood culture bottle at 37 degrees centigrade, and routine incubation time is 48 hours. But for blood culture, it takes 5 to 7 days. And if it's endocarditis, you have to incubate for 2 weeks. And if it's something like fungi or HACCP group of organisms, you have to incubate for 21 to 28 days before you declare it as negative. Looking into blood culture methods, there are conventional and newer automated methods. Conventional methods you use monophasic media, that is BHI broth 50 ml volume, or a biphasic media. And automated blood culture systems include BACTEC and BACT-alert bottles. We'll be looking into what they are. First, let us know about conventional blood culture method. So once you draw the blood, you inoculate it into the brain heart infusion broth. You incubate at 37 degrees centigrade for 12 hours. Then you remove the bottle and you draw the blood with a syringe, inoculate it into solid media, that is blood agar and McConkey agar, and streak this blood onto the plate, and the next incubate it at 37 degrees centigrade to look for the growth next day. If there is growth, you have to report, you have to proceed with Gram-Stain biochemical testing and antibiotic sensitivity testing. But if there is no growth, then you have to repeat the subculturing at after 24 hours, still negative after 48 hours, and you have to continue this up to 7 days. If even at the 7th day it is negative, then you can report as negative. So this is the picture on the left is a uninoculated blood culture bottle, the brain heart infusion broth. It's an important spotter. And the one on the right is after inoculating the blood. What is the disadvantage of conventional methods? Very laborious. There is high contamination rate because every time you're subculturing, you might introduce a contaminant into the broth, and prolonged incubation is also needed. Looking into newer or automated blood culture systems, these systems, they perform continuous monitoring of blood culture bottle. The blood culture bottles are monitored every 15 to 20 minutes to detect the growth, and once there is a growth of bacteria, there is a positive signal given by these instruments. So these instruments include BACTEC and BACT-alert bottles, which measure the carbon dioxide production from the microbe. And once they give a positive signal, the bottle is subcultured onto solid media, that is blood and McConkey. And again, these solid media are incubated at 37 degrees centigrade to identify the pathogen. And what is the use of these newer automated methods? You can identify aerobic bacteria, anaerobic bacteria. There's special bottles available to identify or isolate mycobacteria. So this black instrument is an automated blood culture system which holds up to 60 bottles at a time or even more than it. And you on the right you can see variety of blood culture bottles available. The one which is green and blue is a adult blood culture bottle, aerobic or fungal blood culture, and the orange capped bottle is the one for anaerobic culture. The yellow cap bottle is for the pediatric patients. It has 20 ml broth, the less amount, that is 20 ml of broth. And the red capped one is for mycobacteria. So how is it giving this signal? How is it detecting the growth in the broth? This is because of it's measuring, continuously monitoring the carbon dioxide production in the bottles. Further, how do you go about? How do you work up the positive blood cultures? Immediately you perform a gram stain from the bottle and you report to the physician if is it a gram positive bacteria, gram negative bacteria or the fungi, and then you subculture the broth onto the solid media and you further identify on the next day with the help of gram stain biochemical testing and perform the antibiotic sensitivity testing. Looking into serology, there are antigen detection methods like immunochromatography methods and antibody detection methods like ELISA, immunofluorescence, which are very useful for any fastidious bacteria or bacteria which are not cultivable. Examples of some of which are typhoid, brucella, coxiella, etc. Looking into endotoxin assay, we use Limulus amebocyte lysate assay. Limulus is a horseshoe crab from which you extract the amebocytes, that is its WBCs, and when the patient's serum is added to these amebocytes, it clots, detecting the presence of endotoxin. Next is the molecular methods, polymerase chain reaction to detect nucleic acid of various microbes, especially the viruses and non-cultivable bacteria. Highly sensitive and specific method. Thank you.